Thank you. I'd like to thank Dr. Urmil and my co-speakers, Dr. Bhavna, Dr. Shalu, for allowing me to speak on. I'm not going to cover lead lesson as most of the parts Dr. Shalu has covered. I'll just cover some of the techniques which we can use when we get the laceration of canaliculus. And we know that damage to lacrimal drainage system can cause so many other distortions like telecanthus, globe displacement, epiphora, and there are lots and lots of ways of injury to canaliculus. Can be by direct laceration, stab wound, dog bite, or cattle care, especially in our area. There can be another varieties of injury can be by indirect blunt trauma, fist or airbag. Most of people, we as a oculoplastic surgeon know that consequences usually 10% suffer from constant or nearly constant epiphora, 40% have symptomatic epiphora with ocular irritation, and 50% fairly asymptomatic in case of functioning canaliculus is not injured. So just rushing to repair the canaliculus, you need to keep this thing in the mind. Naturally, primary repair has got definitely higher success rate, but secondary repair also can be done, and when it should be done within 48 hours. For that, you need to have controlled conditions for operation room, proper anesthesia, magnification, optimal illumination, and endoscope. So what are the step one? What we all know when you want to find out the canalicular laceration is a simple location of severe cut end. So it is really difficult, but then you have to locate the severe cut end. The first thing is always inspect and inspect whether you are able to see, observe the Flaringa's ring reflex. It's much better, but we all are not lucky enough to get this Flaringa's ring reflex every time. You may support it with irrigating cannula, fluorescein or BSSS, yellow viscoelastic or methylene blue, but that also creates the mass. Once you get the step 1, the step 2 is confirmation of the procedure. So whenever you are passing and you passing the probe with the red rod technique, you can confirm the thing. And then third step always is a stanting. That is you need to put stand bicanalicular or monocanalicular. It's up to your choice. And step 4 will be a pericanalicular suturing. So we have lot many things available with us, like mini monoca, which is very easily available. People are using it very nicely, and you can, but for that you have to know where the cut severe end is there. You can just pass it into the Flaringa's ring reflex. The advantage of canalicular mini monoca is it has got reduced punctal injury or cheese wiring. It is very easily retrieved, but it is very costly. So all the tribal people, everybody will not be able to afford all mini monoca, which is costing quite high. So cheapest option came, which is easily available in operation room, as a Teflon sleeve of a intracath tube. So we can use this Teflon sleeve of intracath. Once we find out the proximal end of the canaliculus, we remove the piston and then we suture the pericanalicular tissue, and we can retain this Teflon part of the intracath, which is available with each OR. And you need to fix it to external surface in order to get rubbing of the cornea by Teflon sleeve. So it is very easily done in upper canaliculus also. You can do in upper canaliculus. It can be done with the secondary stricture also. The advantage of Teflon sleeve is it is very cheap, and it is available with each and every surgeon. But it creates local inflammation, and most of the time it is a non-biological material. It is not invert material, so usually it extrudes within 7-8 days, so that you have to take care. Then we have an idea that we can use pigtail probe. You can see the pigtail probe is a very gold standard, but the probe itself is very thick. It has got traumatic and it has got eye, so it is very thick. So sometime it may injure the even non-injured canaliculus. And another disadvantage, what I said, is pigtail is very thick. The most important part when you are dealing with the canalicular injury is finding out the severe cut end. So one fine day, this is the patient, which is a post-operatively next day cataract surgery. You can see still air bubble is there and hit by a road accident, and that was a canalicular laceration. I tried all whatever method I said, we could not find. So I just dilated the non-injured end of the punctum. I took 4 Oprolin suture. I band the needle. I cut the needle with simple mosquito artery forceps. This is the second surgery. I kept the etio emery stone, but in first surgery I just rubbed it with my serrated end of the artery forceps to make it blunt. But this is the second surgery, so I had my emery stone available, readily available etio embryo stone. So I just rubbed it. I made the end blunt, and then I just dilated the non-injured end of the canaliculus. Now I am holding the needle, and it is a pigtail itself. I am holding with the cart needle holder. Here you have to see that you cannot push, let it go by itself. You have to unlock the cart, lock the cart. You pull the lead margin so it goes in the right way, and you can see it has come out through the other cut end where you don't have to search for the cut end. So and it is already proline, so I took a chance to use the same material as a canaliculostomy also. So I just passed the same suture into other end. We tied the proline suture, and now the canaliculostomy is ready with proline suture itself. So and now you can see there is a Flaringa's ring reflex, which is very easily seen, but it's not easy to see every time. Then I sutured the pericanaliculus tissue, and then finally I just cauterized the end of the proline suture so it doesn't rub the cornea, and I kept it for few days, and then later on I removed the canaliculus. The same technique I used in pediatric patient also. This is whole literally avulsion of lead. I use here 6O proline suture. I made it blunt on table. Same technique I use. I got the end very easily, and then I sutured the pericanaliculus tissue, and child was doing very nice post-operatively, anatomically and functionally. So this is very cost effective, easily available, easy technique. It's very less learning curve, surety of finding the cut end of the canaliculus, which we are not able to find, and no other stent material is required. They did same procedure in 10 more patients, published the article also, but then later on I came to know that this proline itself is a very strong suture, and then knot can irritate the cornea, so that can be a corneal irritation. So and it was not very and what about the post-traumatic strictures or iatrogenic strictures, what we can create? So we developed Drashti Netralaya canaliculostomy silicone intubation set, which has got the same needle. Now it's already readily available blunt and same curve, with it is available in 21, 22 and 23 gauge for the age specification. So here we are using the same technique, but silicone material is readily available behind that, so we can just pass the same silicone tube, and we can tie it later on, and just we tie these two silicone tube and just pass the knot in the under the canaliculus. It is very more advantage, above said all the advantage of my simple pigtail technique. It could be used in avulsion lead also. Sometime when there is a avulsion lead, you have to support it with double arm 4O proline suture, and this thing was used in child also. We use 24 gauge here, and it is doing very well. And then provided by systemic antibiotics, steroid antibiotics 4 times a day, a steroid combination, and syringing. And you can do on table also, even post operatively you can do syringing just near the stent, and you can confirm it is patent. Then also came the my idea in mind. It is little bit disadvantage is, if not used skillfully, it can create the false passage, because you are pushing something. It can create the false anastomosis, cannot give confirmation of surety of the right passage when both the canaliculi are involved, and after, of course, it can be used secondarily to create new passage when both the canalicular are stricture. It can be used. So, because the complication we can deal with the newer technique is false anastomosis. Cheese wiring can happen, which can happen with any kind of canaliculostomy, ocular irritation, or sometime granuloma formation. So now we are coming up with design with the olive, same intubation silicone set with the olive tip. So that can take care of the other false anastomosis part also. So as I said, primary repair is utmost important, and it is really a team approach. Have healthy recovery to all of your patients. Thanks to all my patients, thanks to all my teachers, and thank you for patient listening. Yeah, I'm applying knot to the silicone. So now we have 3-4 techniques more also. When you apply knot to the silicone, you have to slide that knot into the canalicular itself, and that should be 10-0 non-absorbable suture. Now, your technique right now is the same silicone. I am putting the with the same
Bhavna.
I am putting the silicone tube over there. So later on, that suture also is available. You just tie and just pass the silicone tube. So silicone tube is outer cover, and not the a non-absorbable suture is inside the tube, which you can tie and just slide. Pull it back, cut and let it go. And the advantage of this is you can purchase one and use in 10 more patients, because later part of the silicone only will be used.
You don't try mini Manoka. I know it's expensive, but routinely you don't try mini Manoka and canalicular tear.
Since it is very available,
This,
available, this technique is available with me, and I am already this silicone incubation sets.
Because
And that's what I'm saying, that you can use same 10 more patients.
right. Thank you, ma'am, for the very nice talk. And as you said, inspection is the most important thing. And we also in medical college, we try to tell our residents कि जो casualty में जब आप पहली बार देखते हो ना, उस time जो आपने manipulation कर दी, that will decide the future of that canalicular tear. So you have to be very particular. उस time पे वो अगर आप Fleringa ring देखने की कोशिश करो, and you try not to manipulate. If you think it is not possible, it is better to be shifted to the main OT than to just do the suturing just for the sake of doing. That is more harmful. So residents should be instructed, especially in government hospitals, because they are the ones who are first of all facing those patients. So with that, we come to our next